Thank you for the introduction. I have no disclosures. So, sacral neuromodulation is a treatment, minimally invasive, for patients with overactive bladder syndrome, non-obstructive urinary retention, and fecal incontinence who failed conservative treatment. A lead is placed transforaminally to stimulate the sacral spinal nerves in its vicinity. Good lead position is assessed by visual observation of an inward contraction of the pelvic floor muscles. Most of us can agree this is a rather subjective measurement technique. In order to obtain more objective data, one could use electromyography to detect these pelvic floor muscle contractions. This was already done by a couple of investigators who subsequently identified the presence of a polysynaptic reflex response, oligosynaptic reflex response, and direct efferent motor response. Until now, it is generally considered that this inward contraction of the pelvic floor muscles is due to reflexly mediated response by the spinal efferents, meaning an oligo or polysynaptic reflex response. This study assesses this hypothesis by examining the relation between a visual contraction of the pelvic floor musculature and when it's recorded by EMG. So we investigated this relation by performing needle EMG, similar as the studies just mentioned, as well as intravaginal surface EMG, which has the advantage to be less invasive and more easily to use. So a quadrupolar interstim lead was placed in 29 patients, and we stimulated with increasing stimulation intensity ranging from 1 to 10 volts. And we recorded each time that a pelvic floor muscle response was visually seen, as well as it was recorded by either intravaginal surface or needle EMG. Okay. We made a distinction between the three EMG responses, and what we immediately can see is that the first EMG response is seen in the clinically most important stimulation intensity, namely 1 and 2 volts, in almost 8% of cases, which is similar as the rate that's seen visually. The second response is only seen in respectively 6 and 40% of cases, and the third EMG response is seen in no case whatsoever. This graph contains the exact same data as the tables just shown, but should give a clearer overview of the relation between the different measurement techniques. So, for example, of the 55 stimulations which were visually seen at electrodes at a stimulation intensity of 1 volt, a first EMG response was seen in 53 cases, while if we look at the second and third EMG response, this was, well, mostly not seen, although clearly at 1 volt a visual inward contraction was seen. So statistically, this association can be assessed by using the weight-kappa coefficients, which shows that there's a perfect association between visual detection of an inward contraction of the pelvic floor muscles and the first EMG response, while no association whatsoever is seen for the second or third EMG response, which leads us to conclude that the inward movement of the pelvic floor muscles during lead stimulation is due to a direct efferent motor response, which can be validly measured using needle or intravaginal surface EMG. In addition, only when stimulation is high enough, it can give information about the neural reflex pathways. And lastly, it also possibly urges us to revise the current thinking about the mechanism of action of sacral neuromodulation. I thank you for your attention.
Thank you very much. Are there any questions from the floor? I have a question. How do you think this might play out then in clinical practice? If you are saying that it's not what we see, how would you deal with that?
Well, actually, it is what we see, but EMG, you have several responses, and it was thought that it was reflexly mediated, so there's an efferent limb, and then it goes back. But we show that's a direct efferent response, and we also show that either by using intravaginal EMG, but also needle EMG, which is actually the gold standard, we can measure it, and we can measure it more often than we can visually detect it. So it's at least as sensitive. and it objectivized the pelvic floor motor response. So
Right.
it's actually an improvement. Yeah.
Okay.
So, sorry, Paul, just from Australia. So with the sacral neuromodulation, so the intensity of stimulation that is then provided clinically is below the motor threshold?
That's a different study.
Okay. No, but when you provide it when it's used in a clinical situation,
Yeah.
it's actually below the motor threshold. Is that right?
No, so that's also, but it's a different study, but we examined it as well. So important first to know is that we looked here at the OR, so the patients are positioned on their belly, and the gluteal muscles are taped. So it's easy to see a motor contraction. If they're awake, you can not do it to a patient. So we use the sensory response. And in this other study, we placed them on a in the gynecological position, and we assessed whether we saw, when we noted the stimulation intensity, when we saw sensory response, as you just mentioned, when we were able to visually see it, and when I was able to measure EMG with this EMG with the intravaginal probe, and we saw that in the majority of cases, we first noted an EMG response, which was, it was 0.2 milliamps before the sensory response, and then a contraction in most cases, I was not able to stimulate high enough to see it because the pain threshold is not that much higher than the sensory threshold. And when I was able to see it, it was at higher intensities than the sensory, and of course, then also the EMG motor response threshold.